compound embolism adhesive achieves instant hemostasis and embolization in over 500,000 applications, with safety and effectiveness guaranteed. Method of use: apply the endoscopic needle and locate the needle in the varicose vein. Inject proper amounts of sclerosing agent, compound embolism adhesive, and glucose solution in turn.
Dear participants of the WEO Super Minimal Invasive Intervention webinar. A very warm welcome to you from all over the world. The WEO Super Minimal Invasive Intervention or Surgery SIMS committee is a newly formed committee, and I'm very honored to be the chairman of this committee. SIMS is believed to achieve a therapeutic effect similar to that of the surgical treatment without damaging organ structure and function. That is, cure disease, recover as before. It will not affect the normal survival time and the post-operative quality of life of patients. Through this webinar, we hope to share with you more in depth what super minimal invasive interventions is, and we will be focused on EGD and name a new treatment method of future medicine. Together with you today, while several outstanding experts in the committee who will be showing their knowledge and expertise during the webinar. Moderating this session today are Professor Chiang from the Renewal Louisiana State University, School of the Medicine in Louisiana, United States of America. Joining him as co-moderator is Professor Linghu from the Chinese People Liberation Army General Hospital in Beijing. I would like to take this chance to thank the sponsor of this webinar, Competent Medical from Beijing, for the great support. I wish you fulfilling and enjoying session.
Thank you, Dr. Linghu. I'm Dr. Kai. I'm going to chair this session with Dr. Chai from Beijing. And the first speaker, Dr. Chai, is going to introduce you the first speaker. Dr. Chai there?
Professor Linghu. Professor Linghu. Please share us with your slide.
Okay. Hello everyone. Today, my topic is the concept and indication and the future of the super minimal invasive surgery, that is the current disease and recover as before. I will talk from four aspects, that is the definition, indication, comparison, and feature of the sense. The SEMS were initially proposed in 2016, and the detail that is in Chinese Medicine Journal. The definition that is chronic disease while preserving the integrity of human organ anatomy. And we will through four channels. That the first one is natural lumen, and the next one is submucosal channel, and the third is multi-cavity channel and the transmural channel. The aim that is chronic disease recover as before. So this is the over the esophagus cancer, early stage cancer. This is the circle lesion. So we use the channel technique. Yes, that is called ESTD. Decision the submucosal layer and the resector lesion. That lesion was completely dissected. That is the muscular prepared. The splatter thickness skin graft was heaviest using a hammer knife, and the skin graft was matched by the scalpel. That graft was shown into an oval sleeve-like skin with that is after we transplanted the skin on prevent the structure. Now that is in other case, that is the gist of the stomach. That's another case of the SEMS. The full thickness resected by dual knife, dual tool, and the muscular prepared layer was clipped at the same times. We gradually resected the tumor, completed. And at the same time, clip the muscular layer. This is the tumor. And then clip the mucosal layer. And this is the descending duodenum props, or big props. A difficulty to perform the resection. So we pull back to the antrum. We use the cylinder drop to lick the root of the lesion. This is the first one. We use the other one. and use the clip. And use the dual knife, resect the props. For this kind of disease, there's a large vessel with convolution. And take it easy. Yes, that's finished. For our purpose, the same. The importance of maintaining organs to the whole human body, that's very important. The side effect of the surgical model for treating the disease by removing organs, that is no change in the model of operation between traditional open surgery and minimal invasive surgery that cause the loss of the organ that have a greater impact on the human bodies. So the same indications, that is for benign lesions, for most of the benign lesions, same is believed to achieve the therapeutic effect similar to that of the surgical treatment. However, it did not affect the post-operative quality of life and other benign lesions, some other not tumors. For malignant lesions, that is same is mainly applied to those in early stage. For lesions in advanced stage, traditional open surgery and minimal invasive surgery was still regarded as the optimal resection method. How we call that is nominated. That is for resection, the lesion that is anatomical location and the disease period approach, and we call it and plus the same resection, such as middle esophageal cancer, T0 transoral same resection. For remove this kind of lesions, that is anatomy, location, and plus disease and period approach, and the same removal. That is gallstone transabdominal same removal. That means the gallbladder is still there. For drainage, anatomical location and plus disease and period approach and plus same drainage. That is, for example, that is pancreatic Chiu cyst and transgastric same drainage. That is the pancreas and the stomach is still there. So the comparison, the traditional surgery, minimal invasive surgery, and super minimal invasive surgery, that's the difference. The first one, that's the traditional model is difference. And this two kind of method, that is the resection organ and the lesions. And the same is not. For channel, that is the difference. For minimal invasive surgery, that's used transmural channel, and the super minimal invasive surgery use 4 types of channels. The purpose, that is this two kind of methods, that is just the current disease. But we said that the current disease and recover as before. And the anatomy changes. Of course, that's these two traditional surgery and the myth is change the anatomy, and the same is not changed. For organ function post-operative, and these two kind of method is changed, but the same is no changed. For life quality, and 2 of them is decreased, but that's why is similar with the healthy person. That is the traditional surgery and the myth, and that is for the stomach cancer, and this is partial or completely resection. That's for the same, and the stomach is still there, and no change of the anatomy. For that is the traditional model to minimal invasive surgery, resection organ model for the treatment of cancer. This is for same treatment with cardiac disease, that is the subtumoral tunnel endoscopic resection stir the cardiac. We establish the tunnel and the resection the tumor. This is the model, and the cardiac is still there, no reflux disease. For this is example. This one is we perform the same, 70 years old. This is 68 years old. We use the mass and the partial of the stomach resection. Two of them is the same stage of cardiac cancer. The difference for this case, this patient they cannot sleep down and just lay and sleep, and that's the post-operative quality of life is lower. For the future of SIMS, that is just from the digestive disease, and will be in the neural system disease, respiratory disease, metabolic disease, and so on. So SIMS that is not just the gastric endoscopy for digestive disease and for all aspects of the medicine. That's the first initial purpose is 2016, and we established the SIMS group in CSDE, and the WEO committee is 2021. Thank you, everyone.
Thank you, Professor Linghu's excellent speech. Now we begin the 5 minutes question and answer section. If you have some question to ask Professor Linghu. First, I ask one question. Professor Ling, my question is the of means is different from the end of medical surgery and traditional surgery. Do you think the SMII will take place of the SMII in the future?
Okay, thank you very much. SIMS is applied to most of the benign disease and malignant disease in the early stage. Although SIMS is believed to achieve the therapeutic effect that is similar to that of the surgical treatment, it failed to treat advanced cancer. Nowadays, MIS is my approach for the resection of lesion. While more and more disease diagnosed in the early stage, SIMS will be widely used and be the leading surgery in the future. MIS will be the supplementary treatment method for the SIMS. Thank you.
Thank you. Thank you for your answer.
This only can be performed by endoscopy. In other words, that's exactly the same like an endoscopy, right? There's no other way you can do SIMS.
Yeah. Actually, not. SIMS is defined as a new treatment model. This model means current disease, just as I say, recover as before. So that is the current disease while preserving the integrity of the human organ anatomy. The purpose of SIMS to cure disease without damaging the organ structure and the functions. No most of our time and the post-operative quality of life, surgery will meet this model could be regarded as SIMS, not matter endoscopic surgery or laparoscopic surgery. The laparoscopic cholecystectomy will prevent gallbladder is also regarded as a SIMS.
Thank you. Thanks. Okay, I think the time is limited today. We're going to introduce the next speaker. Okay, our next speaker is Dr. Evgeny Federov from Russia. He's a professor in the NI Pivogos Russian National Research Medical University. He is the head of endoscopy there. Please, Dr. Federov.
Thank you very much for your kind invitation and introduction. Dear colleagues, dear chairmen, it's my pleasure to be the part of this honorable meeting. And the question which I raised here, are we eligible to use super minimally invasive interventions for GIST of the esophagus and stomach? And I would like to draw your attention that it's not an answer. This is a question. And I would like, or we would like to have an evidence-based answer for this question. As Professor Linghu just mentioned, and in-depth explanation of super minimally invasive interventions, they meet the standard curing the disease while preserving the integrity of human organ anatomy. That's why, to clarify my question, are we eligible to use endoscopic enucleation for the treatment of localized T1 and T2 GIST? Of course, without no regional lymph node metastasis and no distant metastasis. Let us see for available clinical guidelines, the last guidelines. For example, if you are looking to European Society for Medical Oncology and European Reference Network for Clinical Solid Cancers Clinical Practice Guidelines, in the chapter of management of local or local regional disease, you will find only that the standard treatment of localized GIST is complete surgical excision of the lesion with no dissection of clinically negative lymph nodes. No any word about endoscopic resection. The same for the National Comprehensive Cancer Network Clinical Guidelines in Oncology, new one, modern one, where the general principles of surgery for primary resectable GIST is a segmental or wedge resection to obtain negative margins is often appropriate, and no any word about endoscopic surgery or endoscopic removal of primary resectable GIST. And going to Asia, looking for Asian consensus guideline or looking for Chinese Society of Clinical Oncology guidelines or for the Russian Oncological Association, you will find the statement that simple enucleation of endoscopic treatment is not recommended even if the GIST is small. And tumor enucleation is not an adequate volume of surgical intervention and should be avoided for GIST. So summarizing these guidelines, we can say that for treatment of localized T2 GIST from 2 to 5 centimeter, all the latest guidelines said that for localized resectable disease greater than 2 centimeter, surgical resection remains the cornerstone of treatment. And the surgery is the only modality for the permanent cure of the localized GIST. It's a little bit inconsistency in the recommendations for surgical resection of gastric GIST less than 2 centimeter. And all guidelines and all reviews and articles mention that the management of GIST less than 2 centimeter remains a somewhat unsettled topic. But given the decreased malignant potential of these tumors, it may be possible to monitor them with endoscopic ultrasound. So it's still challenging situation. But from the other hand, in the last 10 years, we see the huge increase in the number of endoscopic removal of subepithelial lesions, including GIST. For example, in our hospital, you can see how dramatically the number of endoscopic interventions raised up in comparison with laparoscopic operation and especially with laparotomy. And if we look for the investigation trials showing the results of different methods of treatment of GIST, from EGD to laparoscopic and endoscopic cooperative surgery, you can easily see that the complete resection rate is close to 100% in most cases, at least not less than 95%, and that the number of recurrency is also very, very low. That's why having in our hands the really powerful instruments, starting from the simple snare resection or ligation of the pseudopedicle under the base of submucosal or subepithelial lesion, and of course with implementation to our clinical practice endoscopic submucosal dissection, which give you the opportunity to remove the GIST, keeping its integrity. Sometimes we can also remove the lesion, keeping the mucosal flap, as it's shown here. We make the incision of the mucous membrane for 2/3 of the circumference of the base and made dissection with the separation of the tumor not only from the muscle layer, as you see here, but also from the mucous membrane. And after complete excision of the tumor and reposition of the mucous flap to the bottom and edges of the post-operative defect. And the question about the minimally or super minimally invasive surgery for GIST, of course, raise up once more after implementation of submucosal tunnel endoscopic resection. And you know very well that we can remove subendoscopic lesions, not only originating from the second and third echo layer, but also remove the GIST originating from the fourth echo layer, and if necessary, we can perform full layer resection and cells growing into the mediastinum. And in difficult cases, for example, in patients with a difficult location for laparoscopic removal, but with intragastric growth and a rather narrow base, we can use so-called combined approach, laparoscopic and endoscopic approach. And if you look through the modified stratification of patients diagnosed with gastrointestinal stromal tumor, you can easily understand that with all our technique, we fit the very low risk and low risk for our super minimally invasive intervention, because the tumor size is more than 5 millimeter. Mainly the mitotic index, even if it's greater than 5, we can add some chemotherapy, and of course we try to keep the tumor integrity without tumor rupture. And if we look for our own results for endoscopic removal, we achieve complete resection in 100 of patients and recurrence with an average long-term result for 5.5 years, 0. Of course, it's because the size of the lesion is not so big, and most of them you see in very low risk group or low risk group according to the risk stratifications of these patients. And I would like to finish my presentation with the 2021 article from Japan, and I agree with the Nishida sensei that endoscopic resection showed good prognostic outcomes. However, of course, we need to be careful in interpreting these prognostic outcomes, because most gastric so-called mini GIST may have an indolent clinical course and do not progress even without resection. Hence, we need to identify features of small gastric GISTs indicating disease progression, resulting in a poor prognosis without treatment. And I agree completely that thus it is necessary to narrow down small gastric GISTs requiring surgical reaction. And I would like to add from my side, and more widely use endoscopic superminimally invasive methods of their removal instead of just waiting and looking. So it seems for me that one of the possible goals of our superminimally invasive committee is to support and organize multi-center clinical trials in order to obtain sufficient evidence for the use of superminimally invasive interventions for the treatment of GIST. Thank you very much for your attention.
Thank you for your
I'm sorry. There's a question of from audience. One of the audience from India, Dr. Datum. He asked about the cost factors. Dr. Paduma. Cost means I think compare with money, how much it costs, those things. Yeah.
Of course, I am not an economist. I am a medical doctor, and I'm working for 40 years now, and for that 40 years, we understand that if something is more, how to say, effective and less invasive, we will find the way to lower the cost of these procedures. So it's not a question at the moment. And it seems for me, once more, I would like to emphasize, I am not an economist, but also from the economical point of view, the removal, super minimally invasive removal of such lesions is much, maybe not much, but less expensive than, for example, laparoscopic or even open surgery. That's my opinion.
Thank you for your answer. I have a question. So what do? You personally do for a GIST in the stomach less than 2 centimeters? You just watch it?
You know, if we, according to ultrasound, endoscopic ultrasound examination, we expect to find the GIST, we more and more not just ask the patient come for the next time, maybe once. And if we see, for example, that the diameter of the tumor became more and more, we of course not waiting for 3, 4, or 5 centimeters. We are going directly for removal. And of course for histological and immunohistochemistry examination afterwards, with mitotic index, with the risk stratification.
Thank you. I guess we'll go to next one, Dr. Chai.
The third speech is Professor Philip Chiu. Philip Chiu is a current professor and chief of division of upper GI at the metabolic surgery department of surgery. He's a director of multi-scale medicine robotic center, and also the director of endoscopy center, Institute of Digestive Disease. And he is also director of Chinese University of Hong Kong Jockey Club Minimal Invasive Surgery Skills Center. And also he has many titles. Today, the professor to give us speech. The title of his speech is Endoscopic Full Thickness Resection for gastric submucosal tumor. You can begin, Mr. Chiu.
Thank you so much. So first of all, let me share my presentation. I hope you can see my presentation. Today my topic is endoscopic full thickness resection for gastric submucosal tumor. I'd like to congratulate Professor Linghu and all our team members that we have successfully started this super minimal invasive surgery group under WEO. So I think it's really nice for me to follow Professor Federov talk, because I'm going to present about full thickness resection for gastric submucosal tumor. And the history of full thickness resection comes from early 1980s, where surgeons in the colorectal arena started to perform full thickness resection over the transanal approach using the TEM and for resection of early rectal cancer. And nowadays, I think EFTR is indicated for mucosal neoplasia with dense submucosal fibrosis, making ESD not possible, or for some mucosal tumors like GIST, carcinoid, schwannoma, leiomyoma. And for the gastric submucosal tumor, I think GIST is one of the commonest mesenchymal tumor that we encounter. And there will be other like leiomyoma, schwannoma, neuroendocrine tumor, or atopic pancreas. So I think previously already summarized by Professor Federov about the indication for resection. And I think GIST is now for most of the guidelines, including the NCCN, for all GIST more than 2 centimeters, they should be resected. And as a surgeon, I think the surgical principle for resection is a margin negative resection with an intact of the tumor capsule, but the lymph node dissection is not necessary. So that makes laparoscopic wedge resection a possible option. But for a dilemma of management of GIST less than 2 centimeters, then that will come into whether we should provide laparoscopic wedge resection. It seems that the patient receives more risk of surgery. Sometimes cannot identify the small GIST because it's too small without extra gastric component, while endoscopic surveillance with US. So it would be on the how frequent should we survey this lesion, and the patient will have anxiety even before the surveillance. Endoscopic resection seems to be now a possible option, with the advantage that we can have a formal histology and we can alleviate the patient's anxiety, and also it becomes a treatment endpoint. But the prerequisite is obviously you need an expert. And recently, the ASGE listed the guideline for endoscopic full thickness resection and submucosal tunnel endoscopic resection. And they classify EFTR into exposed and non-exposed EFTR. For exposed, it's also subclassified into non-tunnel and tunnel. Tunnel is actually similar to STIR, while for non-tunnel, they would go into ESD technique, completely resect the lesion and then close the defect. For non-exposed EFTR, the bowel segment should be closed before resection. So nowadays we have devices like FTRD device from the Universal company, or using the Gerdex device to close the mucosa before resection. So looking into the non-exposed EFTR like the STIR, in fact, as also summarized previously, that the on-block resection rate in this meta-analysis is in fact very high, up to 94%, and the complete resection rate is 97%. But during the procedure, we always been worried about breaching the tumor capsule, because during the submucosal tunnel, we are quite working in a very narrow space. So it may be ideal for management of leiomyoma because we are not so worried about tumor recurrence. But if we are managing GIST tumor in a tunnel, we might worry that it's dissecting too close to the tumor, causing tumor remnant. So that will come into the possibility of on-block resection with either a laparoscopic endoscopic collaborative surgery or EFTR. And I think, as already mentioned, the advantage of having just a totally super minimal invasive approach is that we do not need to have a skin incision, so the patient have an even better post-operative outcome and much lesser pain. So I just like to show a short video about the endoscopic full thickness resection for management of a gastric GIST located at the proximal body over the greater curvature side. So this is my method of EFTR in the stomach. So first, I mark around the lesion and then inject some mucosally with the normal saline and the indigo carmine and the epinephrine. And I open then half the circumference of the mucosa in order to expose the tumor. I do not open fully the mucosa because sometimes I like to preserve part of the mucosa for an easier closure of this defect. And then during the dissection, we'll be very closely looking at the tumor border and to avoid damaging the tumor border. And then afterwards, I always use the creep and the line technique to achieve a retraction over the tumor. So after applying this creep and the line, and it happens to be a surgical suture because I'm a surgeon, then we retract and then expose the tumor here. So you can see now the tumor border. And sometimes we need to use different devices, for example, like using the IT nano. And now we are already inside the peritoneal cavity. So, and then afterwards, I usually use a two creep and line in order to have a better exposure. So you can see in this tumor, half of the tumor is in fact outside. But if you can expose the outside of the serosa, then you can see very clearly the tumor border. So we can then cut into the serosa and ensure a good tumor border resection. So here, following the tumor border and the abnormal vessel, then in combining the use of the dual knife and also the IT nano, then I can complete the dissection and en bloc resection. So after a certain dissection, then I can just pull the tumor inside the stomach and complete the resection. And the first thing I usually do is to take out the tumor by the use of the rod net, because I worry that the tumor might drop into the peritoneal cavity. So after taking out the tumor, then I reassess the defect here. So I think it's more than 1 centimeter or up to 2 centimeter in size. So in that kind of large defect, I generally will use overstitch from the Apollo company. And in this overstitch, it is actually a single channel type. So it can be used in a combination of any single channel endoscope. So, and then after the application of a figure of 8 suture, then I would tighten the suture with the casing. And then usually I need at least 2 figure of 8 suturing in order to confirm a tightness of the closure of the defect. And then this is the final closure effect. So you can see it is quite secure in the closure. So I think suturing is a good method. If you have the suturing, then nowadays the Apollo overstitch can have a single channel or double channel. But if we don't have the Apollo overstitch, then you can also consider the use of the creep and the loop closure. And I think this is also very secure, especially in the location of the tumor, like at the cardia or even at the proximal fundus, where the Apollo overstitch cannot reach that location. So some of these lesions need the conversion. So for example, if most of the component of the GIST is outside the stomach, then I think probably the best choice is to convert into laparoscopic endoscopic collaborative surgery, like in this case. So we have compared our outcome of having STIR against endoscopic full thickness resection, finding that the hospital stay may be 1 day longer for EFTR, but the en bloc resection rate is higher for the EFTR as compared to STIR. And I think there's another study published a few years ago comparing laparoscopic wedge resection against EFTR, showing that the procedure time is shorter for EFTR and intra-procedural bleeding is smaller, but the amount is probably clinically not relevant because 25 cc versus less than 1 cc, and no difference in the complication. So I think in the future, we might actually combine the exposed and the non-exposed technique. I think this is a wonderful, innovative approach reported by Professor Goto from Japan. So first, he performed a circumferential incision, afterwards developed a tunnel after closure of this mucosal defect, and then performed a full thickness non-exposed resection within the tunnel, and then finally closing the tunnel with the suture. So in summary, I think management of gastric GIST should be considered according to current technique. guidelines and risks of stratification, and also in considering the patient preference and psychology. Full thickness resection is indicated for management of GIST, which are size usually generally less than 4 centimeters. And endoscopic full thickness resection is technically challenging, require advanced skill, especially in closing the defect. And I think in the future, new device for EFTR should address the issue of maintaining the resection space and safe and secure closure of the luminal defect. So thank you very much.
Very good talk, Dr. Chiu. Very good talk. My impression is, most of the Asia doctor perform exposed full thickness section. The doctors in Western country, they usually perform non-exposed full thickness section. I think, because less experience in ESD in this Western part, we are just so worried about the exposed full thickness section. Do you agree with that?
Yes, Professor Tsai. And actually, I think the condition will be more controlled if we have a non-exposed type. So the best is actually closing the defect before we resect. The problem is that we don't have such a large size defect closing device nowadays available. So we can, in fact, the same surgical principle, the wedge resection also close the defect by the staple gun before cutting. So if we can have such a device applying endoluminally, then I think this is an ideal method for management of this lesion, and a probably more easier and a control environment as well.
Mm-hmm. Thank you. There's a question from the audio again, use of EUS for determining level of invasion and also metastasis. How feasible? Again, so, from Dr. Data in India. Yeah.
Yeah, I think this is a good idea. And I think sometimes EUS will help, especially when we are managing GIST of less than 2 centimeters in size. I generally will perform the CT scan before decision because sometimes the GIST can be very big outside the stomach. So that may require laparoscopic combined with endoscopic management. But EUS will be very helpful for GIST less than 2 centimeters. First, to locate the lesion. Second, to identify how much extra gastric component. So that would be a good option.
Okay, Dr. Chai, I think we move down to the next speaker, okay, because of the time's limit. Next speaker is Dr. Deliang Liu, and Dr. Liu is from Central South University in China. He's a professor and also the head of the GI department there. Dr. Liu, please.
Thank you very much. I would like to talk about the difficult peroral endoscopic myotomy. Focus on its definition about the following 4 topics: brief introduction of POEM, definition of the difficult POEM, risk factor of difficult POEM, and treatment strategies for difficult POEM. First, I would like to present a brief introduction of POEM. As we all know, POEM is a kind of minimally invasive surgery, first reported in 2008 for treatment of acrolegia in hormone. Now, POEM has also been applied in other esophageal motor disorders besides acrolegia, and has shown satisfactory long-term efficacy. The efficacy of POEM is better than other endoscopic methods, and is comparable with laparoscopic head myotomy, with less trauma, fewer cost, and faster recovery, but more post-operative reflex. About the definition of difficult POEM, although most of the POEM procedure could be mostly completed, difficult POEM doesn't occur in several cases. Different experts proposed different definition. In 2019, we wrote a review about difficult poem, and we proposed our definition. Difficult poem is characterized by prolonged procedure time, occurrence of major intraoperative adverse events, or aborted poem procedure owing to the morphological or pathophysiological changes of esophagus. Dr. Bichard proposed a further score to evaluate the technical difficulty of poem. The form contains 5 parameters: fibrosis, orientations, using, dislocations of tenor and spastic contraction. However, these are all intraoperative parameters, therefore not suitable for predicted technical difficulty before poem. Several studies has reported the risk factors of difficult poem. The risk factors and potential reasons are listed in the table. Submucosal fibrosis and sigmoid type esophagus are well-known risk factors. So what can we do for difficult poem? I would like to talk about several tips. First, create a short tenor of 6 to 8 centimeters. This is suitable for sigmoid type achalasia and type 2 achalasia. As we demonstrated that a short tenor did not show compromise when efficacy compared with standard tenor length. Secondly, for patients with submucosal fibrosis, sigmoid type esophagus or with peroral endoscopic or surgical treatment, we can use submucosal injected to present the tenor to avoid the fibrotic or sigmoid area as possible as we can. And this strategy is also helpful when we got lost in the submucosal tenor. Just show the endoscope out of the tenor and present the tenor route in the esophageal cavity. For patients with severe submucosal fibrosis or sigmoid type, concurrent tunneling and myotomy is also a good way. This is sigmoid type achalasia. No enough submucosal space even after we inject enough solution. Therefore, in current tunneling and myotomy was performed. Although circular myotomy is usually performed in poem. For thickness myotomy at the esophageal gastric junction may be performed in the following patients: achalasia with submucosal fibrosis, achalasia with previous endoscopic or surgical treatments, sigmoid type achalasia. As for thickness, may ease the poem procedure, as well provide better efficacy in these patients. For patients with spastic esophageal disorders, it is important to ensure adequate myotomy to cover the proximal spasms, and this can be achieved by pre or intraoperative examination result, such as IFLIP. This is a patient with diffuse esophageal spasm, and myotomy was performed at the upper segment of esophagus. After the treatment, the pressure decreased to normal. One open has been reported for patients with submucosal fibrosis with previous endoscopic or surgical treatments or sigmoid type achalasia. However, it is confined to case report, and the open poem violated the primary principle of submucosal tenor technique. Therefore, we don't recommend it. For achalasia, patients with diabetic colon, myotomy contralated to the diabetic colon is recommended. Simultaneous diabetic sepectomy maybe an option for zinc. At last, I would like to give a brief summary for the topic. First, poem is a safe and effective method for the treatment of achalasia with satisfactory middle to long-term efficacy. Secondly, Various factors may result in difficult poem. The two well-known factors are submucosal fibrosis and sigmoid type achalasia. Thirdly, most of difficult poem may be completed by modifications of poem procedure. This table summarizes the risk factor of poem, its potential reasons and possible solutions. If you are interested in this, please see in detail the full text of the review. Thank you for your attention.
Okay, thank you for your lecture. And there are some questions. One question come from the chat box. The question from Dr. come from Actina. His question is the poem post if the poem is failure, how to do, and if some difficult associated with a worse efficacy.
Thank you. Generally, it only increases the technical difficulty or risk of procedure-related complication, while has little influence on the treatment efficacy. However, patients with sigmoid type achalasia or spastic esophageal disorders may respond worse than those without these situations. As sigmoid type esophagus is the end stage of achalasia, although poem could relieve symptoms in these pains, it's difficult to obtain substantial morphological improvement. And in a meta-analysis, the clinical success rate of type 3 achalasia, diffuse esophageal spasm, and netcalculated esophagus was 92%. 88%, and 72%, which is lower than those without this situation. In whom the clinical success may be to 95%.
Any more questions? Let me see. Oh, there's a question of population rates. Dr. Liu.
How about the population rate?
You know, this question I can answer for Dr. Liu. The population during poem is difficult to give a definition, you know. And because, you know, you are in a tunnel. If you myotomy, you perforate, but your mucosa is still intact. So this kind of population, usually you do not have to worry, okay? Unless you have some mucosal injury, then you examine end of procedure, you can endoclip the mucosal injury. So population at the poem is not a severe problem at all, okay? I hope I will answer your question, okay? All right, Dr. Chai, could you introduce the next one?
Yeah, the next one is the last one is Professor. The last one is Professor Xiu Duan. Professor Dong-Wan is a full professor and chairman of Department of Gastroenterology, University of Ulster Medicine College, Enqiang Medicine Center, which is the largest teaching hospital in South Korea. He was the director of Digestive Endoscopy Center. He survives WEO as the Secretary General and is currently WEO's treasurer, as well as a founder of the WEO International School of US. Please Professor Su.
Thank you, Professor Chai. It is my pleasure to join this meeting. I'd like to share my PPT file now. It is already recorded, so I will play this. Thank you, Chairman. It is my real pleasure to join this super minimally invasive intervention webinar. I'd like to congratulate Professor Enqiang Linghu for conducting this first webinar successfully. The title I'm going to cover is Super Minimally Invasive Therapy of Pancreatic Tumors. There are various types of tumors in the pancreas: neuroendocrine tumor, mucinous cystic neoplasm, and pancreatic cancer. How are we treating these cases? Current principle is, if the lesion is purely benign, regular follow-up is recommended. If it is malignant or potentially malignant lesion, surgical resection is generally recommended. However, surgical resection carries significant morbidity, even mortality, and long-term functional disability is the major issue. During the last decade, EUS-guided intervention made remarkable progress. It started from EUS-guided pseudocyst drainage, then moved to biliary drainage, pancreatic drainage, and gastroenterostomy. And nowadays, we are doing EUS-guided tumor ablation and vascular therapy and pain palliation. EUS-guided tumor ablation is actively investigated for pancreatic cystic tumors and solid tumors. Compared to surgery, it carries less morbidity and no mortality. And above all, it can preserve the pancreatic endocrine and exocrine function. So if it is effective enough, it can be super minimally invasive therapy for pancreatic tumors. These are the areas I'm going to cover during 15 minutes talk. Let me begin with ethanol injection for the treatment of pancreatic solid tumor. EUS-guided ethanol injection is generally indicated for small, benign tumors such as insulinoma, neuroendocrine tumor, and solid pseudopapillary neoplasm. This is 99-year-old gentleman admitted because of recurrent attacks of hypoglycemia. At the time of hypoglycemic attack, the patient's insulin and C-peptide was markedly elevated, suggesting the presence of insulinoma. But the CT scan did not show any identifiable mass. This patient was consulted for EUS examination, so I did linear EUS examination on this case. I checked pancreas body and tail first, but there was no identifiable mass. But in the head of the pancreas, we can see about 1 cm sized hypoechoing mass. I added contrast-enhanced EUS examination, and the sonoview was used for this contrast-enhanced EUS. After contrast injection, 15 seconds after, we can see very strong arterial enhancement on the right side. This is typical finding of neuroendocrine tumor, including insulinoma. So based on typical clinical history and biochemical data, and also EUS finding and contrast-enhanced EUS finding, I thought this lesion was the culprit lesion causing recurrent attacks of hypoglycemia. But the problem was, what kind of treatment should we offer to this case? This is almost 100-year-old gentleman, and the pancreas head resection may not be a good option because of high surgical morbidity, even mortality. Chemotherapy may not be advisable. Observation is not possible because of recurrent collapse. I decided to treat this case by a EUS-guided ethanol injection. This is at the time of ethanol injection. 22-gauge needle was inserted into the hypoechoic mass. The bottom half was already ablated, and we are targeting the upper half of the lesion. At what about 0.2 cc ethanol was injected into several parts of the lesion. 3 days after treatment, we repeated contrast-enhanced EUS. Left side is before treatment and the right side is after treatment. If you see the red arrow area, before treatment we can see clearly contrast enhancement, but after treatment that area shows no contrast enhancement at all. This means there is no viable tumor vessel inside. So we confirmed this lesion was ablated effectively. And after this treatment, the patient never had hypoglycemic attack again. This table summarized the result of EUS-guided ethanol ablation for PNET. If you look at the table, although the number of included patients are not that many, there are many different groups using this method for the effective management of PNET. These are more recent data. When we focus on the effectiveness of this treatment, for functioning tumors, the effect is very high, almost 100%. But when we focus on non-functioning neuroendocrine tumor, the effect complete resolution rate ranges from 50% to 80%. These are current issues of EUS-guided ethanol injection. The injection method is not standardized yet, and the amount of ethanol injected is not calculated scientifically. It is more of empirical treatment. And remnant viable tumor is another issue. The next area is EUS-guided RFA for solid tumor. Our group was interested in EUS-guided RFA and started the collaboration research with the STARMED company, which is one of Korean company producing RFA devices. We designed a prototype EUS-guided RFA electrode. These are current indications of EUS-guided RFA. Neuroendocrine tumor, solid pseudopapillary neoplasm, pancreatic cancer, and adrenal tumor. Although there can be some controversies, I think the indication can be widened more if we accumulate more data and experience. This is another case, 69-year-old female showing enhancing nodule in the body of the pancreas. And initially we did follow-up. 4 years later, the tumor showed size increase. So we did EUS-FNA, and it was confirmed as pancreatic neuroendocrine tumor. The patient refused the surgery, but anxious on the size increase. So we decided to do EUS-guided RFA. This is EUS view showing well-defined hypoechoic mass. For RFA, we used the 19-gauge RFA electrode and inserted the needle inside the tumor and activated with RF power of 50 watts, and one side ablation is just 10 seconds. After one side ablation, we changed the needle direction to cover another area and repeated this procedure to cover entire tumor. When you apply electrical power, we can see echogenic bubble formation because of the tissue heating. This is just one plane ablation. If we change the needle direction to another plane, there is still non-ablated area. So we inserted electrode to this non-ablated area again and started RFA. You can see clearly echogenic bubble formation. And 6 days later, we did follow-up contrast-enhanced EUS. And the left side is B-mode image, right side is contrast-enhanced image. Upon B-mode images, it is not clear which area is ablated and which area is still viable. But on contrast-enhanced EUS, we can see contrast-enhancing still viable area. So we started a second RFA on this viable tissue and repeated the procedure again. This is called the contrast-enhanced EUS guided RFA. It is very effective to know remnant viable tissue. Now, 3 months after, the follow-up CT showed marked decrease of the tumor. 6 months later, the lesion became rudimentary. This table shows the summary of our experience. We enrolled 1 insulinoma and 2 SPN and 7 neuroendocrine tumor in our EUS-guided RFA trial. Among them, 70% of the patients showed complete response, morphologically complete response after EUS-guided RFA. Complication, there can be some abdominal pain or self-limited pancreatitis, but there was no life-threatening complication. This table summarized the EUS-guided RFA result for PNET. If you look at the effectiveness, most of the cases shows very good results, and the adverse events are not that many, and there is no life-threatening complication. This is pancreatic cancer patient. On this CT image, we can see a large tumor already infiltrating into the surrounding tissue and the post-photomesenteric junction. Since it is initially unresectable, we decided to do EUS-guided RFA plus chemotherapy. So we combined RFA and chemotherapy. Just before chemotherapy, we added RFA. It increased the delivery of chemotherapeutic agent into this local area. On the follow-up CT scan, we can clearly see marked size decrease of original pancreatic cancer. From this case, we can understand that if we combine RFA wisely to chemotherapeutic agent, then it may increase the effect of chemotherapy. These are potential complications after EUS-guided RFA of pancreatic cancer: pancreatitis, MPD stricture, perforation, or bleeding. When we are trying RFA of pancreatic tumor, we should remember that pancreas is very close to many vital organs. Next item is EUS-guided ethanol injection for cystic tumors of the pancreas. This video shows the techniques of EUS-guided ablation of pancreatic cystic tumor. If there is any growing cystic tumor in the pancreas, we can use EUS for the delineation of the lesion. Under linear EUS view, we can identify the cyst and inject the needle and aspirate the cystic fluid. After aspiration, we can inject ethanol again and re-aspirate and re-inject. This is called ethanol lavage. After lavage, if it is necessary, we can instillate small amount of paclitaxel inside the tumor. These are ideal indications of cyst ablation. Unilocular or oligolocular cyst, size ranging from 2 cm to 6 cm, and without malignant foci and without clear MPD communication. There are several technical variations. Classic technique is ethanol lavage, but we can modify it as ethanol retention therapy, while we can combine chemotherapeutic agent injection such as paclitaxel injection. This slide shows serial changes after 2 sessions of EUS-guided therapy. Initially, it was a very large cystic tumor. 3 years later, it became smaller. After second session of therapy, started to show size decrease again. And 7 years later, the cystic tumor is completely disappeared. We analyzed long-term outcomes after US-guided ethanol ablation of pancreatic cystic tumors and reported the result in Endoscopy 2017. A total of 164 cases were ablated, and among them 6 patients lost follow-up. So we analyzed 158 cases. Among them, complete resolution was observed in 72% of the cases, and partial resolution in about 20% of the cases. Persistent cyst was observed in about 8% of the cases. We also analyzed the recurrence rate after initial CR. During median follow-up of 6 years, and some patients received follow-up more than 10 years, the recurrence was observed in only 2 cases. The recurrence rate was 1.7%. So we can say US-guided ethanol ablation can be a durable type of therapy for pancreatic cyst. In summary, US-guided ablation can be applied for the management of pancreatic, solid tumors, and cystic tumors. For solid tumors, US-guided ethanol injection or RFA is commonly done for benign or malignant tumors. For cystic tumors, US-guided ethanol lavage or ethanol retention therapy can be used, and if necessary, we can add small amount of chemotherapeutic agents. Ladies and gentlemen, I'd like to conclude my talk with this last slide. US-guided ablation therapy can be effective in selected group of patients with acceptable level of post-procedural complication, but further studies are required to increase the efficacy and to avoid complication and for widespread use of this technique. Thank you very much for your kind attention.
Thank you for Professor Su's speech. In your slide, the Professor Su introduced some different methods, different super minimal invasive method, and the effect to deal with the different pancreatic tumor. Any question?
There is a question from Argentina, from the audience. Experience about RFA for solid lesion. Is that through endoscopy ultrasound? I think that's it, right? It is.
Yeah. Thank you for the question. During my talk, I already showed several cases of solid pancreatic tumor, and we did ablation by using RFA method. The RFA probe, yes, it went through the endoscopic ultrasound, the instrumental channel. So it is possible we have experience of doing US-guided RFA for pancreatic solid lesions.
Mm-hmm. That's a very impressive data, Dr. Sear. Very impressive. You have a long time follow-up. It's very impressive. And
yes.
My question, maybe I missed your talk. My question is, how many sessions usually you have to do? How many sessions?
For in RFA or cystic lesion, which one do you specifically mean? RFA or ethanol ablation?
In solid tumor.
Solid tumors.
How many sessions?
For RFA, for pancreas, we can compare RFA of pancreatic lesion and hepatic lesions. For hepatic tumors, we have done percutaneous RFA for a long period of time, and we accumulated a lot of experience, mainly done by radiologists. And for pancreas, we have limited experience, and the lesion size is generally smaller than hepatic lesions. And one of the differences for pancreatic lesions, we are using just needle type electrodes, but for hepatic lesions, they have different designs of electrodes, such as multiple prongs can be used. It can create larger area ablation. But for pancreatic lesions, the electrode should go through the instrumental channel of echo endoscope, so we can only use needle type. So the ablation volume is limited. So if the lesion size is more than 1 cm, 2 cm, generally we do 1 or 2 sessions of RFA. Initially, we do RFA, and then several days later, we repeat EUS and we do contrast enhanced EUS and try to find the remnant viable tissue. At the time of first RFA, it looks like most of the lesions are ablated effectively, but when we went through several days later, there are still viable tissues. So to eradicate those tissues, we do generally 2 times of RFA.
Mm-hmm.
Yes, I have one more question, but
yes,
it's actually for Professor Liu about the difficult poem. Sometimes we have the difficulties post-procedures, not intra-procedures only. So if we have some sort of thrombotic event post-procedure, like DVT or pulmonary embolism after POEM, how to deal with this difficult situation? Should we start anticoagulation? Should we postpone? When to start?
This question is to Dr. Liu.
Professor Liu, yes, yes.
I don't know, he's still, I'm not for sure he's still there. Okay.
He's there, but I think he missed the question.
What's your question? I'm sorry. I'm
about if we have this difficult situation post-POEM, not intra-procedures, if post-POEM we have like a DVT or pulmonary embolism.
I see.
And we need to give anticoagulation, and we already did POEM.
Good question. That's a very good question. I think, I can answer for Dr. Liu probably, I think this question is very good. Number one, it's not happen very often, okay? And I don't know your experience. In my experience, I've done like, almost 1,000 those things. DVT happen 0, Number two, I think if necessary, you can start the anticoagulation because the tunnel, the tunnel inside the tunnel bleeding is happen not very often also.
Okay.
So I think if necessary, you can do it.
It's okay.
I hope I answer your question.
Yes. Yes.
That's a good question. That's a very good
yes,
question.
Yes, we have a case for pulmonary embolism post-POEM. Like 1 day after, and we were thinking what is the best solution to do for this. And we did actually what you advised.
If some thrombosis can be life-threatening, in that situation, we have to balance, the life-threatening situation with the losing some blood from the tunnel. I would think an anticoagulation.
Actually, we started anticoagulation. Yes. Yeah. Yes, we started actually tunnel collapse within 48 hours, and actually we started anticoagulation. Yes.
Especially after a day or two, the tunnel inside tunnel bleeding is very, very unlikely.
Very low. Yes.
Okay. The mucosal the collapse by themselves.
Yes.
The tunnel close very fast.
Yes, it's collapsing.
Yeah, very fast. Good question. Yes. Okay. I think no more question. Then I'll.
Okay. We will come to the have to come to the end of the first webinar. I would like to take this opportunity to thank you for your enthusiasm and hope that you have found the session useful. I would also like to thank all the speakers, moderators, panelists for showing your knowledge. We look forward to your future participation. Thank you.
Thank you, everybody.